everyone. This is Susan, and today Erica and I have a wonderful podcast to share with you. It's a rich discussion of something that seems like it would be mundane, hip pain, but it was a patient with chronic pain that had a couple of twists and turns. I think the one thing about this podcast that's a lot of fun is the idea that we discuss back and forth, changing our evaluation techniques to actually match what's actually happening real time with the patient. So have a good time, and thanks for listening. Hello, everyone. This is Susan Clinton and my co-host, Erica Mello. We're tough to treat, and we are starting podcast number 3. The last 2 podcasts we discussed one of Erica's clients, and we had so much fun talking that it took us 2 podcasts to have to put it together. We'll see how this one goes today. Erica, how are you today?
No, I'm awesome. No fog today, and it's beautiful weather. Yeah. So I'm looking forward to it. I listened to the first one, and I just thought that, I had so much fun doing it. So I'm looking forward to hearing your client. It's awesome.
Yes. Well, it's kind of rainy here today, so I'll just keep my eyes on my paper and think about complicated patients rather than missed opportunities. All right. So actually, this is kind of more of a recent patient that I had come into the clinic. 41-year-old female with a 4-year history of right hip pain. Right off the bat, she came to me because she was referred by another physical therapist that told her, maybe I would be able to help her sort out her situation. And she sat down. It seemed like a really simple patient, right? Right hip pain, heard it doing yoga 4 years ago, hasn't really gotten it much better. I kind of thought, we're going to home right into that hip and, do some manual therapy and get her better and get her out the door. Well, you have to listen to the entire story, right?
Exactly, I know.
And so as the story unfolded, it became quite apparent that this was a bit more complicated than just a right hip pain problem. So it was very interesting. She, 4 years ago, feels like that she injured her right hip doing yoga. And she is a latecomer to yoga, so she thinks. She started her yoga practice probably about 5 years ago and loved it so much she went all in. And after about a year of doing yoga, she started noticing that she was having problems with her right hip. And so it kept getting worse, and she was having to limit and change her yoga practice quite a bit. So she became concerned, and she went to her PCP, who told her that, she probably should just stop doing yoga for a while. Just what they always say, right? If it hurts when you do it, don't do it.
Don't do it. Right.
Exactly. So she didn't like that answer very much, so she went on and found an orthopedic physician who immediately did some x-rays, didn't find anything on the x-rays, told her that it probably was just something, like a labral problem and not to really worry about it and to just scale back on things that bothered it. It would probably get better. And so she kind of went on with that, and still, again, not any better, and was actually feeling like she was getting worse. And even though she was scaling back, and she was only doing yoga then about once or twice a week, and then eventually she completely stopped her yoga practice altogether because she felt like she was doing more harm to her hip than good, but did continue to teach yoga, although she wouldn't demo during class. So at this point, she had sought out physical therapy twice. The first time they did heat and e-stim.
Yeah,
they told her that they did e-stim to her glute muscles because they told her that her glute muscles were not firing.
Oh God, help us.
And hamstring stretching, and just some step-up exercises, sidestepping, trying to work all the muscles around the hip a bit. And she said it was not helpful. She said it felt good at the time, of course, but didn't really feel helpful. But then she began to really worry about her glute inactivity, and that became a huge focal point for her. At this point in the exam, she really wanted to delve into the whole idea that there's other muscles that just aren't working, and I think I have a neurological problem now because why would my muscles not fire when they're supposed to? So her feelings and fear around her hip are really starting to climb as she's kind of gone through this 4-year journey.
Just kills me when someone starts to say your glute muscles are weak, and they do this ridiculous intervention with, an electrical stim machine. Now the patient has a cognitive barrier and an emotional barrier added to the physical barrier now that you have to overcome because they got lousy therapy to start with, you know?
Right, exactly. And you know, she's really latching on to these things that they're, you know, that they're saying. She's already latched onto a labral tear. I mean,
Right.
she's latched onto that really hard, wearing that as like you would a piece of jewelry. This is what I am. I'm a labral tear. I'm no longer this person.
Yep.
And now I have, you know, a neurological problem that's making my muscles not fire correctly.
Yep.
You know, so then she went to a different physical therapist, but they didn't sync up well. So she had the good sense to say, this isn't the person to treat me. You know, and that happens. You got to be, you know, the consumer needs to find, you know, they need to find the right fit.
Yep.
And I'm not always everybody's right fit. And I'm
Yep.
happy to refer them to other people that could be their better fit. You know, we just all have different kinds of, but anyway, she didn't really want to work with this gentleman. So she ended up going to see a physical medicine and rehab doctor, and one that I highly respect in the area. And one of the things that he did offer her is, you know, he told her that she could have a hip labral repair, but he at least was up on the literature to know that, you know, it's really not going to be much different than having, you know, a, you know, physical therapy or conservative care.
Yep.
However, since you're having so much pain, we could try to do a couple of things. One of them is the plasma-rich protein injections, or the other one is stem cell injections.
Oh, interesting.
So, and he felt like the stem cells might help rebuild her labrum. So she decided that she wanted to wait on that because it's extremely expensive.
Yep.
But she's kind of holding on to that as like, and then if I get some good physical therapy from you, I'll be able to go have the stem cell and I'll be okay. And so it's like, okay, I kind of get that with you, but let's back the train up a little bit. Go ahead, Erica.
No, I was going to say, number one, with the PRP or stem cells, I've had patients who've had that and it may have healed whatever their, you know, diagnosis was or their pain, their area, but it didn't really help heal them and didn't make them feel better in their, you know, in walking or sitting, whatever. And I also had a patient who had a labral tear, had surgery in Ohio, and she didn't get 100%. I mean, she didn't really get full function or relief. And so she came to see me. And at the end of the day, with your patient, I often find with the 4 years, they're compensating up the wazoo. And with my patient who had the labral tear, same thing. You end up looking at compensations. And I think that for them to latch on to stem cell and PRP it shows the desperation that these patients are, you know, really have, right?
This was really one of the things that tipped off that big yellow flag to me. I knew that she had a cognitive component to this central processing issue around her symptoms, but this was one that really tipped it off, you know, really strong. When they're considering very, very expensive and non-well-researched type procedures, you know, they're, you know, so she's really feeling like something is completely damaged and wrong in her hip. So anyway, she did, you know, one of her friends did refer to me, so she decided to take a chance and came on in to see me. And so we were able to kind of sit down and, you know, talk and listen to her story. One of the questions I like to start asking people is, you know, so I just asked her, I said, so what do you think is going on? I wanted to hear how she was going to frame it. And, you know, she really felt like that her hip joint was in great danger because of this labral tear, that it probably wouldn't heal, and would I be able to live with this or not, or is this going to be a real problem for my hip as I go forward and I'm not doing the things I want to do, such as yoga, walking, exercise, different things, because I'm very worried about my hip. So she kind of was able to give me her story along that line. But one of the things I did was I kind of asked her to just kind of take me back to 4 years ago when all of this started, and to just kind of give me the story of what else was going on, you know, all of the other stuff in her life that was going on at the same time. And she was able to, you know, she was able to really identify that there was not any moment where she felt a pop, a snap, you know, it was that movement that I did that day, I hurt ever since that time. It was a gradual, insidious onset.
Yeah.
You know, and then she was also related a very interesting piece of history as she was going around that. She also was going through a big breakup of what she thought was going to be her forever guy. Her grandmother passed away,
Oh,
and she changed jobs.
yeah. Major life
Those
events.
3 major life events,
Yep.
right?
Yep.
Not
Yep.
just 1, 3.
Yeah.
And
Yeah.
she said that at the same time that all of this was going on, she also started experiencing gut issues that she had never had in her life. And she started having problems with bloating and not feeling good and, constipation, and then into diarrhea and constipation, diarrhea, kind of back and forth a little bit. And she said that, she started beginning to worry that she was having food sensitivity. So she, in the meantime, has done some good things. She's, kind of changed her diet a little bit, made sure that she's not really taking in a lot of dairy because she had heard that that could be inflammatory. And, but she said, she's continuing to have some skin hypersensitivities all over. And, and then she started having right hamstring pain while she was sitting there. And
while she was talking to you.
Right, while she was talking to me. And she said it was familiar, that she has it all the time. And I said, is this what prevents you from sitting? And she said, actually, this prevents me from sitting more than my hip does.
Oh, interesting.
Very interesting, right?
Yeah,
And it's
yeah.
okay, this is starting to, give me kind of a clearer picture that there's a little brain smudging going on here. And, she's, here's a sign that's saying get up and move, but she's not paying attention to it because she's still wrapped up in her hip.
So her main issue was she couldn't sit, and that was her main.
Sitting was the biggest problem, but activity, like if she would walk or stand for long periods of time, she would have issues with her hip. But sitting, it was mostly the posterior part of her thigh.
Oh, interesting.
That was getting her. However, she said so she could sit about 30 minutes at work, and then she would need to get up and move around a little bit. But I asked her how long her commute was to and from work. She said an hour. I said, how do you do in the car? Well, actually, driving doesn't bother me. I listen to things that I like to listen to, and it's really not a bad thing. I just don't really have a lot of problems in the car. Now, if I was to drive for 2 hours, it would probably be problematic a little bit. But my drive back and forth from work isn't a problem. So there's some inconsistencies there.
Yes.
But one of the things that was cool is that when she's engaged in something that she enjoys, she's not having the symptoms. So, so that was kind of an interesting piece as well.
Yeah, it's that element of distraction, right? The brain,
exactly,
focuses on what's more important, and at the time, I find that common even in myself, even though because I have issues right now with my own hip and my foot. I find that if I'm on the phone or listening to a podcast when I'm walking to work, I don't really feel it. It's very, it's really fascinating, especially with the inconsistency. I mean, this driving. I mean, a lot of people who can't sit can't drive.
Exactly.
Yeah. Yeah.
So it was interesting. I just kind of let her, and I asked her, I said, what she thought about that. And, she was able to kind of start to pull some pieces together. She said, I understand the pain thing. I've read about it. I've listened to a couple of, YouTube videos, and I've been really trying to tell myself that, that this is just my brain making me have pain, and that it's not, that it's not my tissue. But I really, I'm trying to will myself out of it. And it's like, okay, well, there's the problem.
Right.
Is we don't get to will ourselves out of it, as we all know.
Right.
It's like we have to learn, we have to learn how to, change the brain. And so it was really nice. We had a nice talk. She kind of got the whole spiel that I do. I usually get out a whiteboard. I draw the brain. I draw the gut. I talk about the connections and the different things that occur, just to give them a little bit of an idea. We talk about the scary things that have come in, that have happened. And I said, and sometimes the brain doesn't know what to do with that. So it just lays it down as an efficient pattern, even though that's not a pattern you want. It's got to do something with it. And so, for you, I said the experience for you has been some gut issues and this pain experience, and they're kind of all tied together.
Yeah. And that's the whole person approach, right? I mean, putting stim to the glute muscles in somebody like this is just going to reinforce that bad motor pattern and that sensorial experience that she's having. And then, you start to sort of, as a patient myself, you start to think about, oh gosh, well maybe it's this and this and this, and then your whole these dims and sims, right? All these danger in me things. Oh, I have this, I have that. My stomach, I can't do this. My glutes, and she starts strengthening her glutes, it makes her worse, and then you have this whole cascading effect, right? And I think that you know, if you can nip that in the bud, which is very hard because when these patients end up in our offices, they've got so many DIMS and these faulty motor patterns and cognitive barriers that, yes, sitting is an issue, you know, but it's just more than sitting, obviously,
Right.
with somebody like that, right?
Right. So
Yeah.
the first thing I wanted to do, so we needed to move into some sort of a, you know, an exam at this point.
Yep.
So I get her up and put her on her feet. And with people like this, one of the things I like them to do immediately is feel differences. Eric Franklin calls it consumer comparison, and I shamelessly steal it from him all the time. But it's wonderful because it makes the brain pay attention to some other things.
Yep.
And,
Yep.
you know, so one of the things I'll do is like kind of just, you know, check in. Where are you standing on your feet? Just feel where they are. Feel where the pressures are. Don't make any judgments. Just appreciate where you are and kind of what you're feeling. And then we'll kind of shift weight in whatever direction they want to shift to and notice a difference. You know, and does it feel different? Yes, it does. When I have clients who don't feel differences, I make them do it with their shoes on and then with their shoes off. Feel that difference.
Yep.
So they can feel it. You may just have to scale it up, you know, for some systems.
Yeah.
And so one of the things that I did with her was, you know, because she was talking about a hamstring issue and, you know, saying it was tight, but I stretch it out all the time, but it doesn't ever feel like it's stretched out.
Is she hypermobile?
It was at this part of the exam, it was hard to say. You know, I didn't really get into like look at all of that just yet. That, you know, certainly is something you want to look at with people like that. It's like, you know, how are they, do they stand and lean on all of their ligaments, you know? So she was kind of standing more in a guarded position. So it was difficult to kind of tease that out. Her elbows and her hands and stuff didn't really look all that, you know, hypermobile, but, you know, she's also 41. So sometimes those hypermobilities change, you know, as we age a little bit.
Yeah.
But I just had her just bend over. Tell me what you feel. Of course, she felt it in her right hamstring, which I found interesting because she was flexing pretty well at her hip, not just in her back or her trunk. No hip issues. And then, you know, so I just had her change her feet. Let's move around a little differently, go wide in a stance, you know, turn your toes in, turn your toes out, you know, changing the bending over, and then go only up to the, you know, the symptoms, but don't go into them. Do that a few times, and then took her back to the regular, and she could move easier. So that was good for her to kind of feel that if movement may be the answer for you rather than not moving. The question is that are you always constantly pushing into that door, right? Running smack into it every time? Or are you like backing off and kind of moving in a region where you can move without symptoms?
Right.
Because that can change things.
Yeah. Did she have any, with her feet in different positions, did she feel the hamstring in all those positions?
She felt it differently. She felt it at different parts of the range. When she got into a nice wide stance, she didn't feel it at all. She was able to go all the way over. And that was a bit of a surprise for her, but, you know, she has not been really practicing yoga for some time. So she hasn't really been challenging her motor system, you know, in some of these different positions in some time. So it was good for her to see that there are ways to bend over that isn't going to take you into your symptoms every time, you know, and it's like, consider moving in a different way. Like, you're still getting to the floor. You still want to pick clothes up off the floor, but perhaps maybe do it in a different way where you're not going to bring your symptoms on every time, and explore that a little bit more so that you're moving, but you're moving in different ways. So the interesting thing, like I said, with this exam is that, you know, she was really flexing nicely at her, you know, at her hip joint. You know, she had some flexion in her lumbar spine, a little bit in her trunk, but not a lot. I mean, it wasn't like the people that, you know, kind of bend and, you know, the whole trunk is flexed and, you know, nothing's happened at the pelvis and the hips. You know, but no issues with her hip.
That's interesting. Did she notice that when she was forward bending?
I just didn't point that out because she was already being confronted. But, you know, sometimes you have to, like, choose your battles. Like, that's for sure. How much can I confront this individual?
I know.
You know, inconsistencies. You know, because I'm trying to get buy-in and not, you know. But you know what you know, as we went on down the road, definitely, I found that I could confront her more with those things. So she could challenge that, you know, thing in her head. What was going on about it. So what I did then is I thought, you know, I'm going to tackle this glute bit here with her. So I said, the interesting thing about muscles switching on and off is that sometimes we just need to put ourselves in a position where they switch on. And I said, the way you're standing isn't bad. I mean, there's no bad standing. It's just that this has kind of become the way you stand all the time. So when you're in this position, there's no need for your glutes to work. Kind of a little bit of a sway back posture, a little forward lean at the hip ligaments, in the front, and, a little quad strategy to hold on. And so all I did was have her sway forward at her ankles. And they stayed the same so that her center of gravity moved forward over her feet, and like magic, the glutes fire up.
Of course.
And we went back and forth with that. So that became kind of a fun thing for her to do, because I had her put her hands right on her glutes. And I didn't tell her that her glutes were working. I just said, put your hands on here and tell me what the difference is from here to here, here to here. Feel the difference. And she said, is that my glute muscle? It was like, yes, that's your glute muscle.
I know.
She was so excited that her glute muscles turned on.
I know. That's a great way to teach them, because people, when you change the center of mass, the body and the nervous system has to adapt, right? So the farther forward they go, what are they going to fire to prevent them from falling over? Their posterior chain, their glutes, and they're like, oh my gosh, and I think that's a great strategy in the initial assessment.
It was really good for her. And then I said, and notice that your calf muscles are working a little bit.
Yes.
I wanted her to just kind of like, we're not just going to focus on the hip. See, these muscles are working a little more now. When you go back, see how they kind of turn off, and now the ones on the front of your feet are working more. So your toes come up, So we were able to actually work that right into an intervention, which was very cool. It was like the forward and backward sway.
Love it.
Just I want you to, and she goes, it feels like I'm going to fall over though. And I said, of course it does, because your balance system is used to you being back behind. So it's got to take some time to adapt too. So just, periodically throughout the day, whenever you get up, just, play around with your sway and see where you are. So, so that was a really good piece for her, because she was beyond thrilled that she had a glute muscle.
Right, just gonna nip that barrier in the bud.
Right, exactly. And as PTs, we can look at somebody's derriere, right, and we can see if one side is switched off and the other one is on.
Right.
I mean, I think for many of us who have had patients who have had nerve root injuries, good nerve root lesions that have really taken muscles down with fatigable weakness, you can really see that flat side.
Oh yeah, for sure.
That where that butt's just flat as a pancake on one side.
Yeah. And
that's what, when people say that they have a neurological problem, that's a neurological problem.
Yes. Yes.
This one was a coordination problem, and it wasn't even that. It was just that the body just wasn't in a position for them to switch on.
Totally.
So the brain's working. It just had no need to why fire up a muscle when it doesn't need to use it.
Be fired up.
Exactly.
Right.
It's not going to be, that's not an efficient way.
Right.
So, and it was interesting because then she felt like her abdominal muscles changed.
Yeah.
She felt like, gosh, I was really holding so hard with my abdominal muscles around my diaphragm. And when I do this, I don't do that anymore. So,
right. I mean, when you're no, I'm sorry, Susan. Go ahead.
Go ahead.
I'm just saying, when because I have this issue as well. When your center of mass is so far back on your heels, you grip with your anterior chain, your diaphragm, your abdominals, and to have someone realize that is a major revelation. And I think because I've experienced that in my own body, and if you see somebody like that, it's just just the turning on, the turning off, the turning on, the turning off. And I think, the brain is real smart. And when it's used to doing something for a long period of time, it's going to take a little nudge to get them to turn on the muscles that need to get turned on. And,
exactly.
People say, oh, I'm so weak. And I'm like, well, you're really not so weak. It's more of an inhibition. And you need to put the body, change that body schema to turn on the muscles that need to be turned on for the task at hand. And I love that. That was great. I love that.
It was fun for her to realize that, because she immediately connected that to her gut issues. So it's like, okay, good. You can go off to the races and run with that for a little bit. And to me, that gave her a tremendous amount of change. One of the biggest complaints she had in her eval was she couldn't sit cross-legged on the floor. She couldn't do, I'm not always the best about the names of yoga poses, but hip openers.
Yeah.
She was having, and she couldn't lay on her back, bend her knees up, and then abduct them,
Mm-hmm.
on that one hip. She couldn't
Yep.
do it. So we got on the bed and decided to do, I just brought her up and I said, bend your knees up and bring your knee towards your chest and, tell me how that, what's happening here with that. So trying to kind of, just go the other direction from the bend over, right? Lay on your back and bend your knees up, just to see kind of what was going on. She was guarding. You could tell she was being careful. And I said, just stop before you have any kind of symptoms.
Right.
And so, and we just kind of played with that a little bit. And then I just said, okay, keep your knees, so she was able to move and not, get worried. She was a little kind of antsy about it. So I didn't want, I wanted to kind of limit her exposure. I didn't want her to have all this fear with it. And so we just added some breathing with it. I said, I want you to concentrate on doing some nice, easy, long exhales while you bend that knee up. So paying attention to the breath, able to bend the knee more, which was good. So I said, here's your homework, right? I want you to practice these long exhales. It's good for the gut. It helps you calm down, give her all that kind of stuff too. And, and it just makes it a little easier, I just use the thing that when we do a little bit of that resisted longer exhale, it kind of tends to bring those deeper muscles on a little bit more. So that's that coordination thing, like your glute muscles. So she had that to focus on and not really focus on her hip, and she was moving her hip pretty well at that point. So with the same kind of strategy, we did the same thing where we're going to, bend the knees up and then abduct the knees out, feet together, knees go out, butterfly wings. And so she was saying, I just said, just keep them even. We know the left one goes really well and the right one doesn't as much. I said, just keep them even and just, stay. Just you snuggle up next to the stiffness. Don't push through it. And so that was kind of what I sent her home with, the sway and those two exercises, and to be very mindful about getting up before she was having symptoms in a chair. At work. So she admitted to, when she would get it, she would tell me that she gets up every 30 minutes, but when she really thought about it, she said, when I'm in the zone of a project, I don't move.
Right.
So she was going to figure out how to either set an alarm on her phone, or on her computer or something to help her kind of pull out of that zone a little bit so she could kind of stay in her body a little bit more and know that it was time to move and not wait. Because I said that maybe, one of the triggers is that, that old brain back there is kind of going, you've been sitting a long time and I can't get you to get up and move. And I want you to move. So I'm going to give you a pain experience so you will move.
Right.
I said, no, I said, pain is a protector, not an offender.
Exactly.
And it could be that, we have it because we're supposed to take action. So if you can take action before, then maybe it doesn't need to be as strong of a signal all the time.
Exactly. And, it's important to note for people who are listening that, she did have right hip pain and posterior thigh pain. And, and because she had all these cognitive and emotional barriers, it's important to address those in the first visit, as opposed to, let me measure your hip external and internal rotation and measure your hip flexion. And I mean, I don't really do that much, anymore either. It's just, and, no matter what type of patient you see, if you feel a need to do those types of measurements, you can perform those throughout the treatment. It's not like you need to do them in the first visit. And addressing what's the most important part in the first visit for her was just these barriers to recovery. And it's not like you had her stand on one leg, none of that, but you achieved, what I think was the most important thing, is to basically just get rid of that the issue that her glutes are weak, the issue that she has a neurological issue, and that she's defined by a labral tear. And that is huge for somebody like that, versus worrying about how to get all these, special tests or other types of interventions, which is ridiculous for somebody like this, right?
Right.
And not helpful.
And everybody's measured her hip. And
of course.
She could probably spout out the measurements. And,
Totally.
So, and I know a lot of people are out there listening going, well, what do you report? And I report, the ways that she's able to move without symptoms.
Yeah, exactly.
That are my exam was finding symptom-free movement.
Mm-hmm.
And
Mm-hmm.
her intervention was adding the breath, a long exhale for control, and to move into different directions in order to activate the posterior chain.
Yeah, exactly. And
That's
you
what
can
my note says. Exactly.
exactly. I
Mm-hmm.
mean, and you can measure, quote unquote, someone's hip flexion, just in a forward bend. How in
Yeah.
the intervention you do, just make a guesstimate at the end of the day. These are everybody was talking about function. That's functional. And you integrate it into the assessment, because with somebody like this, if she were to have gone to somebody else who just had all these a similar type of evaluation in hip flexion, you would have lost her, and I think that we as therapists, we get so focused on certain things we have to do, and we lose sight of the person that's standing in front of us.
Right. I wanted to focus on what was important to her.
Yep.
And what was important to her was that she was going to be able to change and get better, and that somebody was listening to her story, and that I heard the fact that she's not doing yoga and she's not sitting and engaging in life in the way that she wishes. So I wanted to give her active things to do, because that was what was important to her. Not having somebody passively work on her, but she wants to be the active person in this thing. And so that's where I kind of focused. As I brought her in the next couple of visits, it was amazing, the changes that she made. She started figuring things out on her own. I found that I could sit this way and it didn't bother me at all. I actually, bit the bullet. I'd been needing a new car for 3 years, and I went and bought a car that has automatic seats so I can move my seat around. I mean, she just started doing all of these things on her own. She's like, and now I feel like I could just drive forever. I wouldn't even be limited at all in my car. She said that work was going better, that she was much more comfortable, and she was actually doing some work standing, some work sitting, moving around. I'd given her a lot of literature on productivity and how it changes when we take breaks, meaningful breaks.
I love that.
Yeah, and so that helped her kind of wrap her head around getting out of the zone in projects. She goes, I'm so much more productive. They don't all do this in 3 visits, right?
I know.
I picked her
highly
on
motivated
purpose because it just was, it's motivating to kind of hear the story. So one of the things we're doing for yoga practice, because she's still very fearful of it, is I just kind of hopped right back into graded motor imagery with her. She went and found some yoga DVDs, that she likes. And I told her, I said, she goes, oh, I think I could listen to it for 20 minutes. I said, well, I want you to do the movement in real time in your head, fire up the premotor cortex, to get going. That's part of graded motor imagery, and to exposure to the thing she's afraid of.
Right.
And I said, and be in the moment and just kind of feel. I said, but you're going to fatigue. You haven't done this in a while. This is, this. And so she came back. She goes, 5 minutes was all I could do. And it's okay. I just like the 5 minutes is fantastic if you can be all in for that 5 minutes. And I love the fact that she was listening to the DVD because it kept her in real time. Because in our brain, it doesn't work if we go, okay, I did this pose, this pose, this pose, this. That's how we like count to 10. One of them is 10. But if you mouth it 1, 2, 3, obviously it slows you down. So the DVD voice guiding, like, okay, and now you're going to move into whatever pose next and hold and breathe. So she was able to, through her brain, do all of that while she was kind of in her nice meditative pose. So she, her marching orders now are, 6 or 7 minutes, to increase the grading. And what she's also doing is in her teaching, because she is teaching yoga every week, I've challenged her to find 2 poses to demo. So she, that she feels very comfortable and confident about. Begin to dip her toe in the water and get back into doing some of these, because it's important to her. And now she's like, she told me when she came in yesterday, she goes, Susan, I sat on the floor with my legs crossed.
Oh, that's awesome.
And I didn't even think anything about it.
That's great.
That was just like, that's
huge. Yeah.
Just unbelievably huge. So she, and she just feels like, so now she's demoing half the class, and she's doing her graded motor imagery. We're going to kind of be working through.
That's great.
She comes across poses that are fearful and challenging. As I get her to start moving into her practice, my plan is to kind of, coach her through those, so
Yep.
that, she feels comfortable and confident that she can progress and move forward without, without fear of quote damage,
Yep. Yep.
to the hip. Going to ask you what you usually do, because she did bring up the hip again and the stem cell, and I just, wanted to know if she should move forward with it. And so my answer to her, and I'd be interested to hear what you usually say to people like that as well. I'm certainly not her PM&R doc. I have no idea what conversations they've had, but I just simply said to her, I said, things are progressing in a way that you're comfortable with right now. And I let her answer that, and I said, and if you're not comfortable with how things are progressing, you need to, that space is here for you to say that. And I want you to feel comfortable in being able to express that. But if you feel that you're moving forward in a positive direction and we're meeting or going towards the things that are important to you, why don't you let this have a little bit more time before you have to make that big decision? That decision can be there, but right now it seems like you're being able to move forward a little bit. And I think what she's still worried about is that that actual damage is there and that her hip, that actual damage needs to be repaired no matter if she has pain or not.
Right, right. I mean, it's true. I mean, at the end of the day, we always give the patient, options. And I think with somebody like that, I would probably have said something very similar. Putting, stem cells and PRP will, in effect, help the local area. However, it's not going to change how you move in your body. And if that's something that you want to consider, I would continue with physical therapy, and because even though you'll get a stem cell or you may get a stem cell or a PRP injection, at the end of the day, you're still going to move the way you move. So if you're just masking movement patterns with these types of treatments, it's still not going to change how you move. So whatever decision you make, you need to change how you move in your body before and after. So that's what I would say. And I think that, I always generally say it's up to you. However, you're doing so well now, I would probably, let's reinforce some good motor behavior. And at the end of the day, we can cross that bridge when you come to it. But if you're doing well and you're happy with your progress, I would, just hold off on that for now. That's something very similar. Because I do, people, like I had my patient a while ago. I mean, she had a PRP injection into her foot. She was miserable. She didn't get any better. It did heal her tendon, her posterior tib, but it didn't make her feel better because she couldn't do a releve, and her main issue was her thorax. So similar to your patient, it's her through the motor patterns, it's her cognitive and emotional issues. For somebody like that, if she ends up getting a stem cell implant or a PRP injection and she doesn't feel better, that's death. I mean,
Exactly.
right? I mean, that would just put her over the edge.
Exactly. You have to sit there with them quietly so that they can begin to space hold that, because you can't roll the eyes. You can't say, "Oh my God, did you not listen to anything I said?"
Right, right.
But but it just brings it back to how tightly ingrained sometimes those scary things are set in people's heads, and they really, really feel that no matter how good they are, they still have that evilness in that joint, and so it is kind of tricky. So I did take her down the path that, you're going in the right direction. You're working on the things that you like. I know there's people out there going, well, what are you going to do about, are you ever going to check her balance one side to one side? Yes, eventually we will do that within the context of the movement patterns that she wants to recover.
Right.
If this was somebody that was a CrossFit athlete, I'd be doing something different. It'd be something that they would be wanting to recover, and we'd be scaling at the CrossFit gym. If this was a dancer, I love that you brought up the releve, and a dancer, and that actually looking up top and how their holding patterns up top could affect their ability to go up and down on their feet. You have to just look at the movement. You don't have to be an expert in ballet, or modern dance, but you do need to understand that, boy, if they just tip their body this way a little bit, that would probably be a much more successful movement.
Yes. Yes.
Or maybe they're, I don't know. I suspect that what's going to be going on with her is my expectation, which I try not to have, but we can't help it, is that she's doing quite a bit of breath holding with some of the yoga poses.
Oh, sure.
So I'm going to make sure that as she moves through her graded motor imagery that she's continuing to do, especially if that pose has an exertional piece to it, that she does some long exhale with it, you know, to kind of give her, you know, just to make sure that we bring that, you know, that not that fear, I can't do it, I can't hold it, and let me hold my breath kind of thing into it, to make sure that, you know, we continue to get that going. And one of the things that definitely is on my agenda for looking with her as I move forward is to definitely look up the chain, you know, and, you know, head and neck and shoulders and trunk and thorax, and how well are those moving? You know, she's starting to move well at her feet now with her sway. She can open her hips and stuff, but I got to make sure that as she moves up the chain, that all of that is brought into this, that's not staying stiff and separate.
Right.
And do you find that a lot with people like that, like hip and knee and foot?
So, because I would, I probably also would look at, and I'm sure, you know, you did, is, you know, just have her squat and see how she's going into a seated position, because that's when, you know, you see a lot of these things that, like my patient last week, you see a lot of these sort of, you know, areas that aren't moving well, you know, and
that's a good point,
you know, and just squatting, and is her thorax compressed, or is her pelvis rotating, or is her head shifted? And these are all just motor patterns. And and I know for people listening as well, you know, that's, you know, a functional move that's important. I mean, you have to get to seated position, you have to squat, and you know, I think some people also, because I'm going to ask the question, and people are going to say, well, she had posterior thigh pain. Did you check a slump test? And if you did not, why didn't you do that?
Okay, and
I'm just being devil's advocate.
Yeah, no, I love it. I love it because with the movement patterns that I did with her, I basically did a slump test.
Exactly.
So, you know, that's why my first thing that I always do is a bend over test, because people bend over. And if it's posterior thigh pain, if it's something, you know, that if that posterior thigh pain had, you know, if it didn't change with any of the, like moving her legs apart, moving them together, moving her feet out, moving her feet in, bending her knees slightly, not bending her knees slightly, and continuing to go over, it becomes like a repeated flexion test, right?
Totally.
And so if it was a dural issue, like a dural sensitivity, that would have raised her symptoms no matter what I did.
Exactly.
Right?
Exactly. You know, you're fully loading someone in a slump, but you're forward bending them, they're moving. I agree totally. And I just, you know, people were, you know, who would be listening, or they would say, well, we didn't do a slump test, but you did. So, and I think that's
and I did it different
important.
on purpose, because she's already been to PT twice and it hasn't worked.
Exactly.
And so you know, in the back of my mind is how much traditional testing was done, and do they already know the answer? Because sometimes there's that, and it's not that they're trying to be a malingerer or a, you know, whatever. I don't believe in any of that. I believe that there's an expectation that when I get in this position, it's going to hurt, and therefore I'm going to say it hurts.
And exactly. So, and I think with, you know, it was great. I loved that whole body sway. And I think, you know, because of these types of patients, you're finding a way into their nervous system, and you found a way. Pretty quickly, you know, and
like I said, this is great.
I mean,
it doesn't come this fast.
It's like, man, that's great. But I love the center of mass and changing the width of the hips and the forward bending. That is, you know, I check center of mass, but I don't do a lot of that forward and backward space. So that's a great intervention, or, you know, assessment. I love it. I really do. Because people like that are just, you know, even in myself, I'm all the way on my right side. I mean, I think as physical therapists, we're so in tune with our own bodies, and but, you know, and we can't see the forest from the trees when it comes to my own body, but with other people, that whole center of mass is really important. And I think therapists overlook that in the first visit, or in any visits, because they're so involved in trying to get stuff done, you know, and she's, you know, that physical therapy that she's had before failed her, you know, and I'm sure that all the other physios did things like that. But, you know, when you see complicated patients, you know, the first visit, you got to find a way into their nervous system. You got to find a way into their system, whether it's from the back door, the front door, the side door, the basement, whatever it is, you got to find a way and just get that trust and that buy-in, you know. And it's not about doing everything you possibly can to get right down on your documentation,
Yeah.
because these are the patients, as I mentioned last week, we're losing them to other professions. And I think, this great sort of, out of the box clinical reasoning process that you have is amazing, because people love this, and they love other different types of interventions and assessments. And I think with this podcast, we're really trying to, enlighten people as to other potential ways of assessing these types of patients.
Well, I love doing this with you because it helps get me out of my conformational biases and my ruts, because I have them too. How many of us treat from the same side of the table all the time? How many of us enter the room the same way every time? We still have our own, kinds of pieces and parts that go with it. And so by changing up and changing how you look at somebody, you begin to open up that creative process again, and it makes actually treating a lot of, not that it wasn't fun before, it's but it's super fun now.
No, for sure, absolutely, it really is.
It really brings a lot of things together. So anyway, this was great. This was fun. I've got some good directions to go with her. For those of you who still have some questions about documentation, one of the ways that I'm documenting for her is that the changes in movement patterns that she has, the length of time that she can do things, those types of things that she reported that were problematic. I'm using those as the measures of change. So I'm not focusing in on impairment, so to speak, as much, but in just the functional movement patterns and participation pieces of her assessment. And that's what I'm choosing to do. So I'll be taking her into more squatting, and we'll be doing some different kinds of yoga stuff next time I see her, and begin to kind of challenge that and expose her just a little bit more to some movement again.
I love the yoga stuff, and I give a lot of yoga poses out as actually sort of corrective types of movement patterns for them to take home with. And depending on the yoga pose, a warrior or triangle, I do love down dog a lot, because
inversion is great.
It opens up the thorax, it's the blood flow. I actually just gave it to somebody yesterday, and you had talked about dural stuff. That's another podcast, but I think that's a nice way of just lengthening the dura. And people who have dural issues, they tend to sort of, I'm using my hands again, they tend to sort of go into this cocoon-like pattern when one part of their system gets lengthened and the nervous system doesn't want that, so they shut down. So I love that yoga, the down dog, and it just really, and with breath breathing, and those are great interventions as well. So this will be fun working with her.
Absolutely.
Very cool.
Okay. So I think that's going to wrap it up for today. This is Susan Clinton and my co-host,
Erica Mello.
And we are Tough to Treat.
Thanks,
for
guys.
listening. Bye.
Bye.